All right, well, kind of jumping around here. We're moving from up to chapter 52 on environmental conditions, which of course involve heat emergencies, cold emergencies, drowning, diving emergencies, high altitude emergencies, those sort of things. So we know that environmental extremes can cause illness or injury in people. Um, environmental emergencies from things like heat stroke or hypothermia, environmental illnesses, things like high altitude sickness. Um, it's important for you to know, what sort of environmental extremes that you'll encounter in the area where you work. Wilderness EMS is a special type of EMS, and it's where we take street EMS and we apply it to wilderness environments. And wilderness EMS is, of course, driven by the local needs. Where I'm at, we certainly don't have long transport times, and wouldn't require any wilderness EMS training, but certainly folks like in Colorado and Wyoming and Utah and places like that. And the big key with wilderness EMS is understanding that you may have the patient for extended periods of time, and so reassessment and reevaluation and perhaps changing what you're doing may be more important in those environments. Now we know that homeostasis is a state of equilibrium, and that we are what we call homeotherms. As a homeotherm, our body strives to stay within 1 degree of normal. And we know that normal body temperature is 98.6. So our body strives to stay at somewhere between 99.6 and 97.6. Any less than that, we can become hypothermic. Any more than that, we can become hyperthermic. Thermal regulation is certainly something that is complex. It involves thermoreceptors on your skin that have a tendency to determine the temperature outside, whether it's really hot or whether it's really cold. And then they send messages to your brain, and certainly once in the brain, the hypothalamus, which is the thermostat of the body, then would send information to the skin, the spinal cord, the abdominal vessels, the great vessels, causing things like, if we needed to conserve heat, causing things like piloerections, which is goosebumps, causing things like vasoconstriction, which shunts the blood into your core to keep you warm. And then if we needed to dissipate heat, causing things like an increase in the amount of sweat, so that the sweat could be evaporated and take with it heat, as well as dilating the vessels, allowing that warm blood to come out to the periphery, where you can eliminate body temperature through conduction, convection, evaporation, and other methods. We know that metabolism, by virtue of what occurs during metabolism, the byproduct is heat. And the more we metabolize, the faster our metabolic rate is, the more heat that we're going to generate. So in people who are working hard, their metabolism is increased, so obviously they're going to generate more heat. In people who are resting comfortably, they're not going to generate as much heat. Or in patients who have a limited energy supply, generating heat does require energy, and if you're lacking sugar and all you have is the oxygen, you're not able to make energy sufficient to meet the demands of the body to maintain your heat, your body temperature. There are external mechanisms to heat and cold response. We have a way to how your body gets rid of heat. Your body may radiate the heat off your body to a colder environment. So when you move from a warmer environment into a colder environment, heat begins to radiate off your body into that colder environment, trying to warm up that room. You may convect heat. And convection is air movement that crosses your body and takes with it some heat. Probably the best example of convection is when you blow on a hot soup spoon. By blowing air across that soup, you cool it off. So that's how convection dissipates heat. It's estimated that if we didn't have wind on the Earth to blow and keep the Earth cool, the average temperature on the Earth would be 160 degrees. Conduction is a way that when we come in direct contact with an item that is cooler than us, then the heat leaves our body trying to warm that object up. So coming in contact with the ground, you have a person who's lying on the ground and the ground is 52 degrees. The longer they lie there on that cold ground, the more heat is being sucked out of their body, or I should say conducted out of their body. Evaporation is the most efficient method that we have to dissipate heat, and that is as moisture is evaporated off our skin, it takes with it a tremendous amount of heat. So heat dissipation by evaporation is the most effective way we have of eliminating heat. There are some other external mechanisms in response to heat and cold that are involuntary. Certainly the warmer it is, the more we perspire. That's not something we can control, and of course the perspiration is to provide moisture to be evaporated to remove the heat. The constriction and dilation of our blood vessels, we really can't control that either. When we're cold, our vessels are going to constrict. When we're hot, our vessels are going to dilate. And then metabolism, as your body senses a need for more heat, initially it will increase your metabolic rate as long as there's enough energy to support that. And then piloerection is a fancy name for goosebumps, where the hair follicles, the sweat glands, pucker up and don't allow sweat to come out or moisture to come out. It's a way of conserving heat. And you all have little piloerections when you get out of the shower, and you might not notice them, but they're there. The voluntary response that one should have when exposed to extreme heat or cold is to seek shelter away from. If it's too hot, move into a colder area. If it's too cold, move into a warmer area. And then add or remove insulation as necessary. It's probably one of the more effective ways of maintaining heat in a cold environment is to layer. And then remove layers of clothing if you get too warm, and add layers if you start to feel cold. Some other things that contribute your body's ability to maintain temperature include the wind velocity as well as humidity. We know here in the Midwest certainly about a little thing called wind chill, and in cold temperatures when the wind is blowing, that certainly has a much colder effect on the body than when it isn't. And as far as humidity goes, heat dissipation by evaporation of sweat ceases when the humidity raises above 80%. So it isn't necessarily the temperature of the environment you're in as much as it is the humidity. If you're in an environment where there is 88% humidity, there's no more room in that environment for moisture. So the evaporation of sweat doesn't occur, and you're not able to dissipate heat that way. There are some predisposing factors that make you more prone to heat and cold emergencies. Certainly the very young and the very old don't tolerate heat and cold as well. Your overall health condition. If you're unhealthy and suffer from a variety of diseases, you don't tolerate heat and cold well. If you're in shock, shock and cold do not go well together at all. Certainly in shock, you're unable to maintain your body temperature because shock is a state of inadequate tissue perfusion. And, if you're not able to get oxygen to your tissues, you're not able to generate heat. If you can't generate heat, you dissipate heat faster then you can produce it, you become hypothermic, and then you shiver. Shivering causes you to burn up energy you don't have, and it just worsens the shock. So shock and cold do not go well together at all. Central nervous system insult, certainly a head injury, may make it so that you're unable to constrict or dilate your vessels, or if as an example, that area in the brain where the hypothalamus is located, you may not be able to regulate your body temperature. Burns destroy the skin. Skin is good at with a piloerection and those sort of things, good at maintaining heat, but when you burn the skin, you lose that ability to regulate your temperature as well. Medications, beta blockers have a tendency to make people colder. Your skin conditions, and then your mental history. Certainly, people with mental disorders, may put themselves in environments, or may not wear the proper, clothing in certain types of environments. Measures to prevent heat and cold injury. As far as cold, we should avoid long periods of exposure to the cold. We should cover exposed body surfaces, layer our clothing, keep our clothing and body dry. The other thing to keep in mind about cold is that if you're out in a really cold environment, in addition to needing more energy to stay warm, the initial body response to being in the cold is vasoconstriction. The vasoconstriction sends the blood to the core, and the kidneys sense an increase in blood flow. That increase in blood flow then causes a secretion of your antidiuretic hormone, and you won't get rid of urine, but you'll produce large amounts of urine. The colder it is outside, and the more your vessels constrict, the more urine your kidneys will make in an attempt to, what it thinks, to get rid of this excess volume. You can lose up to 2 liters of water in one day in a really cold environment. As far as heat goes, avoid long periods of exposure to heat. Drink plenty of clear fluids or sports drinks. Use shade to reduce the heat. Avoid using diuretics. Avoid using amphetamines. Limit your alcohol intake. I noticed it didn't say avoid alcohol intake, but certainly limit your alcohol intake. And reasons for that is the metabolism of alcohol consumes energy and also water. So the metabolism of alcohol can make you dehydrated. And you couple that with a really hot environment and sweating a lot and not replacing clear liquids or sports drinks, you can become heat exhausted. So let's look at some heat emergencies. Heat cramps is one. With heat cramps, the issue is a sodium and electrolyte loss from sweating. So as a result of the sodium and potassium and calcium loss, you're going to get muscle spasms. You're going to be fatigued. And this occurs with extended exertion in hot environments. Of course, the treatment for that is they're going to have findings that they have heat cramps. They're going to be a hot environment. They're going to be overexerting themselves, sweating a lot. They're going to have cramps in their fingers, their arms, and their legs, and their abdomen. A differential diagnosis. Other things that may look like heat cramps include tetany. 1 second here. Tetany and other heat emergencies like heat exhaustion or heat stroke, or just simple muscle cramps as a result of perhaps a low potassium level anyway. How we take care of heat cramps: get them out of the heat, hydrate them with electrolytes, some sort of sports drink, and in certainly extreme situations, establish an IV of NS or LR and give them a little fluid bolus. Heat exhaustion, in addition to the sodium and electrolyte loss, you also have dehydration. It's sort of a compensated hypovolemia, so it's kind of compensated shock. There'll be lots of sweating. Vasodilation with venous pooling out in the periphery. Your container becomes larger, it's half as full, and then you're sweating a lot. So again, in addition to losing electrolytes, you lose a lot of water. And again, you're going to have a period of extended exertion in a hot environment. Physical findings: rapid shallow breathing, weak rapid pulse, flushed or pale skin, cool or clammy skin in the later stages when they're in mild hypovolemia, heavy sweating, a normal core temp that can quickly rise anywhere from 100 to 105 degrees Fahrenheit, and they may present obviously with dehydration. Some differential diagnosis is dehydration from some other cause, because their altered mental status is present. Then maybe you might think hypoglycemia. Because they're hot, you might think infection. Because of their odd behavior, you might certainly think that they're intoxicated. Treatment is going to be very similar to heat cramps. You're going to get them out of the hot, keep them flat, hydrate them if they can swallow, do start an IV, do give fluid boluses, and certainly lower their body temperature if they're hot. Heat stroke is an increase in core temperature over 105 degrees with a decreased level of consciousness. In that particular situation, the hypothalamic temperature regulation has been lost. Your body has no way to dissipate the heat, and as a result, those high temperatures lead to cellular death of the brain, the kidneys, and liver. The hallmark presentation in heat stroke, in addition to being extremely hot, is an altered mental status. And as cells die and metabolism isn't normally maintained, you may develop metabolic acidosis and high potassium levels. Classic heat stroke is present during long periods of heat and particularly really high humidity exposure. It affects the very young, the very old, diabetics, alcoholics, and those with cardiac history more so than others. People who take diuretics, psychotropics, or anticholinergics are at greater risk of developing heat stroke. And although hot, red, dry skin may be a finding, it's a very late finding if you see it. With exertional heat stroke, this would be a person in a really hot, really humid environment who's exerting themselves. They have a sudden rise in core temperature during the exertion. All ages are susceptible to this. Patient is found with not a lot of fluid deprivation. It's just a sudden increase in temperature. The skin may be a little sweaty, but they're not drenched in sweat like you see with heat exhaustion. Physical findings: an altered mental conscious, disorientation, maybe even combative as the temperature rises and those other things set in, hallucinations, seizures, high core temps, ataxia, tachycardia, tachypnea, hypotension, and unconsciousness and death. Some differential diagnosis: heat stroke may certainly look like a stroke itself. It may look like hypoglycemia, infection because of the high temp, uncomplicated dehydration, intoxication because of the altered mental status, and neuroleptic malignant syndrome. And here they're talking about malignant hyperthermia, which occurs primarily in operating rooms. Therapeutic interventions is you got to cool them down quick. You got to replenish fluids if they've lost a lot of fluids, but remember they may not, and how sweaty and drenched their clothing are might be an indication for the need for fluids. But you've got to get their core temperature down. If they're unconscious and seizing, certainly that requires you to manage their airway, stop the seizing activity, so IVO2 monitor as well. Hypothermia is described when a core temperature is less than 95 degrees. It's the result of exposure to cold or not being able to produce heat as fast as you're losing it. Hypothermia comes in two varieties: primary hypothermia, which could be accidental, it could be homicidal, could be suicidal, and formerly was known as acute hypothermia. Secondary hypothermia is something that you might see as a result of complications of sepsis or trauma or cancers. It was formerly called chronic hypothermia. During hypothermia, your body has ways that it can try to conserve heat, with piloerection or the little goosebumps being one of the first things that you might experience. Shivering, you get those large muscle masses moving so that they'll generate heat. An increase in muscle tone. Vasoconstriction to shunt that warm blood into the core. That does cause an increase in cardiac output, and again an increased blood flow to the kidneys, so an increased production of urine. And then an increase in respiratory rate as well. As the core temperature drops, that tells you that the compensatory mechanisms have failed. The metabolic rate then drops. Metabolism comes to a crawl, and then cardiac output drops, leading to shock and death. Mild hypothermia is considered between 93.3 and 96.8 degrees Fahrenheit. Moderate hypothermia is 86 to 93.2, and severe hypothermia is less than 86 degrees Fahrenheit. Poikilothermic would be, I'd have to look that term up. I apologize, I didn't catch that in my review of the PowerPoint, so I'm going to have to look up just what that means and let Cherry know. But typically, no one has survived a core temperature less than 86 degrees Fahrenheit. Some predisposing factors that make people predisposed to hypothermia include alcoholism, only because they may put themselves in situations where they're in cold environments and can't get out. Burns from real excessive heat loss. Hypothyroidism, that's a low metabolic rate, so not able to generate heat, and you may be in environments where you're losing it faster than you can generate it. And then extremes in ages. The very young, because of their body surface area is so much larger in relationship to their mass, that they get rid of heat very easily and can become hypothermic even in warm environments. And then the very old, who just have trouble regulating their body temperature, especially if they're on like medications where it doesn't allow for vasoconstriction or doesn't allow for an increase in heart rate, those sort of things. Physical findings: assess the environment. Certainly if the environment is cold, the patient can be hypothermic. So cold would be anything less than 97.6. So if you're in an environment of any temperature less than 97.6, there's a potential for somebody to become hypothermic. You can get a core temperature via the rectal thermometer. That's the best way to get a core temp. Many services may not carry a hypothermic thermometer, because if you look at a normal thermometer, I don't believe it goes below 96 or 95 or something like that, where you need a hypothermic thermometer if you're assessing a patient who's really cold. Stunned peripheral sensation, in other words, numbness or tingling in their extremities, may impair the patient's ability to feel that they are injured. With mild hypothermia, the heart rate's normal, the blood pressure's okay, the skin may be a little pale, dry or wet depending on their hydration status. Their speech may be a little slurred, they may be shivering. They may have uncoordinated movement, impaired judgment, impaired fine motor skills, and sluggishness. We say that the mild hypothermic patient gets the umbles. They mumble, stumble, and grumble. And in many old patients or many geriatric patients, certainly they may mumble, stumble, and grumble, and we often just think that it's because they're cold, or they're old. But in reality, it may be because they're cold. Moderate hypothermia, the respiratory rate's decreased, the heart rate may be normal or bradycardic. You may start to see arrhythmias like atrial fib or PVCs. Blood pressure could be adequate or starting to become hypotensive. Skin may be pale, cyanotic, or mottled. There may be confusion, stiffening of muscles. Shivering is present, but shivering stops below 89 degrees. So if you've got a really, really cold patient that isn't shivering, you know they're less than 89.6 or less than 90 degrees. And then ataxia, the inability to walk with any sort of normal gait. Severe hypothermia, these patients look dead. They've got decreased cardiac output, cerebral blood flow, fixed and dilated pupils, slow, shallow, or absent respirations, pulmonary edema, slowed heart rate. You may see some Osborne waves on the ECG, and their skin may be cyanotic or mottled. And it's very difficult to see, but the Osborne waves seen in V4, 5, and 6 are on the back side of the QRS, where you have that little positive upright wave at the base of the QRS in 4, 5, and 6. A differential diagnosis, certainly somebody might be diagnosed as being intoxicated or have had a stroke or a head injury when in fact they're just cold. Therapeutic interventions include to prevent further heat loss, get them out of the cold environment, remove wet clothing, eliminate wind blowing on them, insulate the patient, passive rewarming instead of active rewarming. Passive rewarming essentially is carried out by preventing any further heat loss. And hopefully if the body's metabolizing, if you prevent any further heat loss, the body will gradually rise its own temperature. Where active rewarming is what they might do in a hospital. This type of therapeutic treatment is certainly appropriate for all ages. Move them into a warm environment, apply warm, dry clothing, insulate above and below the patient with blankets. Sometimes, depending on the severity of how cold they are, we may leave their arms and legs outside of the blankets. This will prevent a situation known as after drop. Now, if we warm up the arms and legs as quick as we do the core, the cold acidic blood from the arms or legs may be flushed out into the core, sending cold acidic blood to the heart, causing it to fibrillate. Active external rewarming and active internal rewarming is certainly something that could be done with chemical cold packs, or chemical hot packs, wrapped in towels and placed alongside the skin of the patient in areas where they normally dissipate heat. Allow the patient to urinate if their bladder is full. If the patient is pulseless and apneic, you may have to take a full minute to determine whether or not they are pulseless and apneic if they're really cold. But after that full minute of checking for a pulse and breathing, if there is no pulse or you're not sure and they're not breathing or you're not sure, they need CPR. So begin CPR. Hook them up to a heart monitor if they're in VFib, defibrillate them, give IV medications, understanding that if the patient's body temperature is less than about 88 degrees, the heart's not going to respond to defibrillation, it's not going to respond to medications, and we should focus our efforts on warming these people up. Frostbite is a situation where part of the body is frozen or tissue is frozen. It pulls water from the cells into the extracellular space, and then those water cells freeze, forming ice crystals that expand and destroy the surrounding cells. Frost nip is more superficial than frostbite, and frost nip is often reversible. There's usually no extracellular freezing with frost nip. Superficial frostbite is just that. It's superficial, it involves the epidermis and the subcutaneous tissue. The surrounding tissue is reddened. It may be white or yellowish firm skin in the area where the superficial frostbite occurred, and it's generally quite painful. Deep frostbite may also cause hypothermia. That's where the epidermis, subcutaneous tissue, muscles, nerves, tendons, and bones may all be cold. The skin is white, hard, and frozen to the touch. Maybe you have a loss of sensation, unable to move or bend the frozen part. And during rewarming, there's a significant amount of pain that may occur. And later, at some point, if enough cell damage has been done by the frozen ice crystals, then the limb may require amputation. Frostbite we certainly see in mountaineers, explorers, tobacco users, because tobacco causes vasoconstriction and poor circulation to the digits, like toes and feet and fingers. They're more apt to get frostbite. Fatigued or malnourished individuals, and certainly soldiers out in cold environment. Some other things that may mimic frostbite include chilblains, pernio, trench foot, cold urticaria, uncomplicated hypothermia, Raynaud's phenomenon. Raynaud's phenomenon it's interesting. People who I know a gentleman who has Raynaud's, and it just affects his fingers, where he'll go out into a cold environment or run his hands under cold water, and immediately all the blood drains out of his fingers, and he has no circulation to his fingers until they warm up. Local infections, ischemic injuries, blunt trauma certainly can all be differential diagnosis. Therapeutic interventions for frostbite is, of course, to limit further injury, defer thawing if there's a chance that it will refreeze before you can get them somewhere. Minimize the movement. Don't have them walk on it. Don't have them rub or massage it. Splint it if at all possible. Trench foot, it's similar to those of frostbite. It generally is above freezing temperatures. The injury occurs over days. The extremity feels cold and numb. The skin appears blanched. And of course we see this, it got its name, trench foot, from the trench wars in World War I, where soldiers were often in trenches that had water in them, and so they stood around in water for days, and their skin got extremely cold. Differential diagnosis for trench foot, all the same differential diagnosis you have for frostbite. Therapeutic interventions, essentially the same. Because this usually involves having your feet submerged in water, get them to a dry area, remove them from that wet environment, start rewarming the area by eliminating the clothing, put warm, dry clothing on. And you're certainly welcome to elevate the extremity. Not sure if there's any real benefit to that, but something that you may consider. If their vital signs support it, they may be in quite a bit of pain, and so establishing an IV and giving them some analgesics is not out of the question. We'll look at submersion injuries to include drowning and some associated cautions. There are immersions, submersions, and drownings. And an immersion syndrome is a sudden cardiac arrest caused by massive vagal stimulation after sudden exposure to cold water. So this would be somebody who had no intention of finding themselves in water and fell into extremely cold water, causing a massive vagal stimulation, a slowing of the heart rate, and a cardiac arrest. Post-immersion syndrome is delayed deterioration of a previous asymptomatic or minimally symptomatic patient. So you have a patient who maybe slip under the water, may have had a submersion injury, and you retrieve them, they're coughing, hacking, and hours later they develop a massive pulmonary edema and get worse. Shallow water blackout is something that occurs in snorkelers more than anything. They don't do a good job of describing it. It just talks about unconsciousness after submersion. But the mechanism here is that if you've got a snorkeler, oftentimes what they'll do is hyperventilate prior to diving down. And the purpose for that is to, if they breathe deep and rapid for a while, they're able to displace the nitrogen in their bloodstream with oxygen, so they have a higher oxygen content in their blood, and they can stay underwater longer while they snorkel. So there's a benefit to doing that. But the problem is that, while you're under the water and you have all this additional oxygen as a result of hyperventilating, you're not... you don't have that urge to surface and take a breath, even though your CO2 levels are rising and rising and rising and rising. They get much higher than normal, but you still don't have that urge to take a breath because of all the additional oxygen that you breathed in before you snorkeled down. And so what happens with these patients is they hyperventilate, they go down 10, 12 feet, they're snorkeling around down there, they don't have a sense or an urgency to surface, and because of the high CO2 levels on the brain, they pass out underwater and they pop up to the top of the surface. Submersion injuries and drownings, as far as associated cautions, it's the second leading cause of accidental death in the United States is drownings. It's a leading cause of accidental pediatric death. Teenagers are the second major group in here. Elderly is the third highest group when it's related to drownings. One child drowns every 7 days in a bucket or a toilet. Not something that we'd think of, but it doesn't take a lake or a river to drown in. The classic sequence starts with panic. People who find themselves in the water and had no intention of being there, or certainly people who find themselves in the water and can't swim, they're no longer able to hold their breath. They may or may not be underwater if they can't slap their hands and keep themselves above water. When they slip under the water, at some point with that high CO2, they'll take a breath underwater. So they have several violent intakes of air and water while they're flailing. They have laryngospasm and bronchospasm, severe hypoxia, acidosis, cardiac disturbances, brain anoxia, coma, and then death. So some other physical findings: drowning may be associated after accompanied trauma, particularly related to diving. Cardiac disturbances are a common cause of, or certainly something that you see in post-immersion patients who are successfully resuscitated, as well as hypothermia. Some differential diagnosis or things to keep in mind is that drowning may occur as a result of trauma, may occur as a result of spine injury, may occur as a result of a cardiac dysrhythmia when they found themselves in cold water. They may have become hypothermic. Certainly in the water, the need to generate heat is much greater, so the consumption of sugar is higher, and a person could become hypoglycemic. They could have seizure disorders or metabolic abnormalities that cause them to drown. Patients with seizures are 4 times more likely to drown than other patients. The priority here in drowning is to reverse the hypoxia or the CNS anoxia. So if resuscitation is required, you have to begin breathing for them as soon as possible. Start ventilating them while in the water is one of the most appropriate things to do, and continue with ventilation when you reach the shore. Up here at the lakes, we look at if the patient has been submerged for less than an hour, that's a rescue. If it's been greater than an hour, then that's a recovery of the body for the family. Complications associated with drowning include sudden respiratory arrest, adult respiratory distress syndrome, release of fluid into the alveoli, and it doesn't matter whether it's salt water or lake water, fresh water, it just doesn't matter. The amount of water that is pulled or absorbed is minuscule in the grand scheme of things, and so for us it makes no difference whether the patient drowns in salt water or they drown in fresh water. They may develop inflammation of the alveoli and lung tissue, which leads to the acute respiratory distress syndrome. Loss of surfactant may get washed out, allowing fluid from the capillaries to weep into the alveoli. They may have a significant amount of atelectasis, collapse of the alveoli. They may develop an aspiration pneumonia depending upon how clean the water is, and they may also develop a pneumothorax. So as far as diving emergency, the thing to keep in mind about divers is that for every atmosphere down they go, and an atmosphere is defined as 33 feet in depth. So for every 33 feet in depth, there is a great deal of pressure put upon the human body. When you think about it, if you're standing in 33 feet of water and you've got 33 feet of water on top of your head, that's a lot of weight. That's a lot of pressure. And that water exerts additional pressure against the body. And fluids are not compressible, but gases are. And so gas-filled organs, the gas in those organs can be compressed and made into a liquid. And that's not an issue when you're down there breathing through your SCBA, if you will, your self-contained breathing apparatus, or your scuba tank, which allows you to breathe compressed air, which is 21% oxygen and 70-some% nitrogen. And all that nitrogen that you breathe in is made into a liquid form and then travels into your bloodstream in liquid form rather than in gas form. So there are a few laws concerning diving physics, and the issue with Boyle's law is as you ascend from the depth and that pressure is let off, gases go from liquid back to gas form, and so there's an expansion of gas in the body as you surface. And the rule of breath for divers is whatever you do, don't hold your breath, because as you ascend, if you're not breathing, then as that gas expands, if you try to hold your breath, the pressure inside your chest can become great enough to rupture alveoli and cause a pneumothorax. So Boyle's law teaches us that we should not hold our breath. Dalton's law says that we should control our breathing at all times. And Henry's law talks to us about avoiding long and repetitive dives. The longer we're underwater and the deeper we're underwater, the greater our risk for decompression sickness becomes on ascension. Excuse me. Barotrauma occurs as physical damage to the body tissue, all as a result of changes in gas pressures between inside the body and the surrounding water around them. When you move from high pressure to low pressure, these gases expand and can cause barotrauma. When you move from low pressure to higher pressure, these gases become liquids, and barotrauma is the most common medical complication of diving. In fact, we're taught that when a diver pops up to the surface, you should be highly suspicious of pneumothorax. Some physical findings of barotrauma include inability to equalize pressure between the nasopharynx and the middle ear. So what will happen on descent is as you're descending, if you're not able to equalize the pressure in your body through your middle ear, then your middle ear becomes extremely painful. You get ringing in the ears, you get dizziness, hearing loss, you can have a rupture of your eardrum, which is extremely painful, frontal headaches, pain behind the eyes. All these things are the result of descending, particularly if you descend too fast and aren't able to equalize the pressure. Ascending injuries, if you hold your breath, certainly obstructions like holding your breath prevent expanding air from escaping, and as a result injures the surrounding tissue. So obstructions, as I had mentioned, could be holding your breath, but it could be something like bronchospasm or a mucus plug. Pulmonary overpressurization syndrome is an expansion of the expansion of the gas damages the lung tissue. You end up with things like arterial gas embolisms. You can end up with pneumomediastinum as the alveoli rupture as you hold your breath. That air may escape into the mediastinum, and also a pneumothorax. Some differential diagnosis that you might think of in somebody suffering from barotrauma from a diving injury might be infection, like pneumonia, Might be decompression sickness, might be trauma to the chest. Your therapeutic interventions are going to be, certainly high flow oxygen, IVO2 monitor, and then injury-specific treatments. If they have a pneumothorax and it develops into a tension, then obviously you're going to need to decompress the chest. Nitrogen narcosis occurs as a result of diving in really deep depths while breathing oxygen. While breathing air in a compressed tank. Nitrogen narcosis occurs because the nitrogen is more soluble under pressure, and all the excess nitrogen that you have in your bloodstream as a result of breathing air out of that tank. Remember, 71% of the air you breathe is nitrogen in it. That nitrogen has a narcotic effect on the brainstem. And as a result, it produces an anesthetic and intoxication effect on the diver. So at really, really deep depths, depths greater than 100 feet, you can get nitrogen narcosis, which leads to a feeling of euphoria, poor thinking, not knowing up from down, and could appear, the diver could appear, if they're suffering from nitrogen narcosis, like they're intoxicated, certainly like they have a low blood glucose, or that they have some sort of CNS infection like meningitis or encephalitis. Therapeutic interventions is to ascend to a shallower depth so that you're not so deep, and then the other treatments would be the same as for bear trauma. Decompression sickness, or the Benz or caissons disease, is what it was first called. It was called caissons disease because caissons were bells or underwater welding platforms or little welding huts underwater where a person could descend, dive under the water with no diving equipment and come up under the caisson, which was pumped full of air and kept the water out so that they could work and weld on the footings of bridges. And if they were down there for long periods of time, the nitrogen would form a liquid in their bloodstream. And then when they swam out from underneath the caissons and quickly ascended to the top of the water, it would cause a rapid excessive expansion of the nitrogen liquid into nitrogen bubbles that would get caught in joints and in the spinal cord and under the skin and in the brain. And this decompression sickness can occur anytime you dive deeper than 33 feet or 1 atmosphere. So one of the key things that divers are taught, in addition to always breathe, not hold your breath, is never ascend faster than your bubbles. A slow, controlled ascent will prevent decompression sickness. Because as you ascend, if you ascend slower than your bubbles, as you ascend and you off gas, you're able to get rid of that gas so it doesn't get caught in your joints. Decompression sickness, or the bends, is generally not visible until the dive is over, and the complaints initially begin with the joints and the abdomen. In fact, the abdomen would hurt so much that the people would bend over, and that's where they got the name bends. The patient will be fatigued. They may have paresthesias, the numbness, tingling, prickling in the extremities. They may have central nervous system disturbances if they've got brain bubbles in the brain, nitrogen bubbles in the brain, and it may take up to 24 hours before you see onset after a dive. Some differential diagnosis, things that certainly may mimic decompression sickness, include fatigue, stroke, intoxication, and brain infections. Therapeutic interventions is to think about recompression is typically what they'll do. In other words, find a bariatric chamber where they can take this diver down to a depth of less than 33 feet or exert pressure on them that they would have felt at 33 feet, and then slowly off-gas them and slowly let the pressure off as if they had done a controlled ascent. Decompression sickness is a diving injury, and to prevent it, you shouldn't hold your breath. You should control your breathing underwater, avoid long dives at depth, get rest between dives, ensure proper hydration, avoid alcohol, and again, make your ascents really slow. Don't go any higher than your bubbles. Altitude-related illness is very similar to diving emergency, but in this case, the pressure up the higher you go is less, not greater. Altitude-related illnesses are the result of decreasing pressure and a lowering partial pressure of oxygen. It most commonly occurs in altitudes greater than 8,000 feet. So when you get out into the Colorado Rockies and you get up into those situations where you've not acclimated yourself to the altitude, and you hop in a car and drive from sea level all the way up to 12,000 feet at the tundra in Estes Park, as an example, you can get really sick with altitude sickness quickly because of the low partial pressure of oxygen. Your body's not acclimated, and it becomes very difficult to oxygenate your tissues. It's called acute mountain sickness. It's the most common of altitude illness, and again, it's caused by hypoxia from reduced O2 pressures, fluid redistribution as well. You have a sympathetic activity to response to this, so your heart rate goes up a little bit. You have a little vasoconstriction going on, those sort of things. Cerebral edema may occur as well, which makes you feel lightheaded and dizzy. Mild acute mountain sickness or altitude illness includes headache, lightheadedness, difficulty sleeping, loss of appetite, breathlessness, fatigue, nausea and vomiting. Severe acute mountain sickness includes severe weakness, severe protracted vomiting, decreased urine output, resting, shortness of breath, altered level of consciousness, cough and congestion because patients develop acute pulmonary edema, the inability to walk a straight line, and the pale or changing in skin color. Some differential diagnosis, of course, you might think you have the flu, might think you're dehydrated, might think you have a low blood glucose, that you've got some metabolic acidosis, that you're intoxicated or have a hangover, or you're just fatigued. If the acute mountain sickness is not relieved by rest, then you need to descend back to lower altitudes. One thing that certainly can decrease the likelihood of developing acute mountain sickness is to, when you know you're going to make a trip up in those particular areas, to make sure that you're well hydrated. Drink lots and lots of water before you make that ascent. High altitude pulmonary edema. This is fluid buildup in the lungs caused by the altitude, the high altitude. You're going to get fluid buildup, which prevents oxygenation and CO2 exchange. You become hypertensive, hypoxic, low blood pressure, impaired cerebral function, and eventually death. Physical findings: persistent wet cough because of the pulmonary edema. It may be white and frothy like you'd expect to see with pulmonary edema. Crackles in the breath sounds, inability to sleep, inability to lay supine without the feeling of suffocating, shortness of breath, rapid breathing, lethargy, irritability, confusion, disorientation, and coma. Some differential diagnosis: you may think it's pneumonia or an infection or fatigue. You may think it's cardiogenic or even non-cardiogenic pulmonary edema. You may relate it to hypoxia, hypoglycemia, or metabolic disorders. HAP, or high altitude pulmonary edema, or HAPE, H-A-P-E, high altitude pulmonary edema. The therapeutic intervention for that is to descend. Administer some oxygen, use specialized non-standard EMS medications to treat the pulmonary edema, things that we don't carry, but in wilderness medicine, paramedic services are stocked with the medications necessary to treat that. And nifedipine, which is a calcium channel blocker, is something that is used. High altitude cerebral edema is the most severe altitude injury, causing intracranial pressure from swelling, excessive fluid leakage and swelling of the brain. Rise in ICP occurs 1 to 3 days after being in the altitude, and it most often occurs if you've been in altitudes at greater than 12,000 feet. Physical findings of high-altitude cerebral edema include disorientation, severe headache, ataxia, decreased level of consciousness, drowsiness that's not relieved by rest, hallucinations, confusion, stupor, and coma. You might think the person's having a stroke or low sugar or has some other sort of metabolic derangement. You might think they're intoxicated or just worn out, but they do have some sort of altered mental status. As with all high-altitude sickness, the therapeutic intervention is to descent, but in the case of cerebral edema, it's important, and in fact imperative, that you descend. High flow O2, IV access, and perhaps a corticosteroid like dexamethasone. Prevention of high-altitude illness, generally slow ascents with rest periods and acclimation. I know when we go out to Colorado, we stay at a height of somewhere around 7,500 feet, and we like to get acclimated at that before we go up to our 10,000 feet perches, and we like to get acclimated at that until we go up to our 12 and 14,000 perches. So generally slow ascents, drink lots of water, rest periods in between, get acclimated, and that will lessen the chance of altitude-related illness. With lightning injuries, that's injuries from a transmission of electricity between the sky and the ground. You can have a direct strike, which of course is the most lethal. You can have a splash injury where the lightning strikes the ground next to you and splashes or travels through the ground and then splashes over the outside of your body. You can have a contact injury where you're holding something like a golf club and the lightning strikes a golf club. Step voltage injuries, blunt injuries from being thrown to the ground, and streamer injuries as well. Minor injuries associated with lightning strikes might include tympanic membrane rupture, so rupture in eardrum, confusion, amnesia, brief loss of consciousness, temporary deafness, blindness, paresthesias or diesthesias in the extremities, as well as myalgia or muscle weakness. Moderate injury from lightning strikes include disorientation, combativeness, coma, motor paralysis, absent pulses due to arterial spasm, sympathetic instability, hypotension, vascular trauma, spinal shock, seizures, and then of course burns from the lightning injury itself. And then severe lightning strikes may cause cardiac arrhythmias, cardiac arrest, pulmonary edema, and pulmonary contusions. Differential diagnosis, certainly lightning strike would resemble something that you might see from a high voltage electricity injury. Therapeutic interventions. We do reverse triage in patients who've been struck by lightning. If we have a pulseless victim, we're going to treat them first over the other victims because the pulseless victim does have a good possibility of surviving the event if CPR is started right away and the patient is defibrillated. The other things we do for lightning strikes is certainly to treat the treat the symptoms that are present, understanding, like with electrical burns, that certainly the damage on the outside doesn't really resemble all the damage done on the inside, and then of course the best method of not getting struck by lightning is prevention measures. As far as snakes go, there are envenomous snakes, snakes that do create venom, that are complex neurotoxins. They certainly are toxic to the neurons in the body. Many have local effects at the bite with necrosis and swelling and pain, and systemic effects as the poison travels through your bloodstream into your brain and your vital organs. Generally, snake bites are only lethal in children and the elderly. Typically, adults can handle the bite of the snake, and if necessary, anti-venom may be available as well. Physical findings, it can cause precipitous deterioration in victims. Distal neurovascular status may be decreased, localized swelling, Um, Differential diagnosis: not all snakes that bite are venomous, and not all venomous snakes, when they bite, envenomate. So that can be a challenge for EMS providers. I certainly have been bitten by snakes that are not venomous, and in being bitten by them, if I would have called a responder or 911, not knowing the type of snake, you really wouldn't know whether it was venomous or not. Non-zoological trauma as well from other bites not related to animals. Therapeutic interventions: immobilize the injured area to decrease the spread of the toxins, keep the victim calm, which will decrease the spread of the toxins, and transport them maybe en route, establish an IV. And of course, the best method of not getting bit by snakes is to prevent it by practicing prevention measures in what you wear, where you go, and what you do when you see a snake. Arachnids are scorpions and spiders. So here we're talking about scorpions, we're talking about brown recluse, we're talking about black widows, and those are the three ones we most routinely address when we're talking about arachnids. We know that the scorpion venom causes paralysis, but there's a whole lot of scorpions in the Midwest, and particularly Nebraska, Colorado, New Mexico, those areas, and only like one of all the different varieties that are there is actually toxic. The others will sting you, but they don't have toxic venom. The brown recluse spider, often that bite goes unnoticed, but by the time it is noticed, it's a red round macular rash that has a little bump in the center that eventually becomes necrotic and sloughs off, and a significant amount of tissue can be lost as a result of a brown recluse spider. Black widow venom causes sustained muscle spasms and abdominal rigidity. With scorpion stings, there's going to be significant local pain. With brown recluse, there's going to be a serious ulcerated necrotic wound with a lot of drainage. With black widow spider bites, there's going to be severe muscle spasms. Again, so hard to differentiate between non-venomous bites and venomous bites unless you know your arachnids well. Dermatitis certainly can resemble some of the rashes that you might see with an arachnid bite. Therapeutic intervention is to keep them calm. For scorpion, black widow, or brown recluse, we don't incise the wound, we don't suck the poison out, we don't do any of that anymore. Just keep the patient calm, splint the extremity that's bitten to prevent the spread of the venom, and transport them to a facility. All right, well, that pretty much wraps up the environmental chapter. I want to thank you for getting caught up with me, and me getting caught up with you, and I'll be talking to you soon as we move into our next section. If not, I'll see you in a bit for AMLS. So talk to you soon.